So I am Dr. Donna Session. I am a reproductive endocrinologist. I'm at the Wilmington Fertility Center in Wilmington, North Carolina, and we're part of the Boston IVF group. And today I was going to talk about some of the causes of infertility. So traditionally, infertility has been defined as trying to get pregnant for a year. In women over 35, we like to do the evaluation after about 6 months and after age 40 immediately. And the recent change has been that our National Society has become more inclusive about fertility. So we're also consider patients who are not in heterosexual relationships as infertile. It's common, 1 in 7 have infertility, so you're not alone. It just wanted to mention, if someone has other reasons for infertility, such as doesn't have regular periods or knows that their tubes are blocked, they shouldn't wait the year or 6 months to seek out help to get pregnant. So I was going to talk about some of the reasons why people have infertility. One of the common reasons in women is anovulation. That's when an egg isn't released each month. And so typically, if someone has regular periods every month, they are releasing an egg. If someone is skipping periods or going a long time without periods, and they're probably not releasing an egg. The way that people can check this is, one is the temperature chart. Some people will take their temperature every morning and plot it on a graph. And after someone releases an egg, the progesterone hormone goes up, and that raises the body temperature about 0.5 to 1 degree. And you can see that on the temperature chart. The reason that a lot of people don't do temperature charts is that it is very time consuming. Sometimes it's hard to tell that you have the temperature elevation, and the temperature goes up after the egg is released. So it's not really helpful for timing when to get pregnant, because by that time you've missed the window of chance of pregnancy. The other tests people can use are the ovulation predictor kits. And they can be good sources of timing things if people have difficulty, if they're in a heterosexual relationship and they have difficulty getting timing when to get together, that's useful. They are a little bit expensive, and sometimes for some people they're difficult to read. For example, if someone has high hormone levels like polycystic ovary syndrome, then they might be positive all the time. So it's hard for those people to tell whether or not they are releasing an egg or not. Typically, if people are not releasing an egg, there's going to be additional testing done, hormonal, to try to figure out the cause of this. And so there can be many reasons that people aren't releasing egg. Common hormonal things are like your thyroid gland, the gland in your neck is off, or something abnormal about the pituitary hormones. One of the very common causes of anovulation is polycystic ovary syndrome, where women have a lot of eggs, they're not reaching maturity and getting released each month. Other causes might be stress, exercise, and menopause, if there's not any eggs to ovulate. Actually, besides pregnancy, stress is one of the most common reasons that someone doesn't ovulate. And so usually we see that in young people in college around the time of their final exams or midterms, where they skip a cycle. So overall, ovulation is a factor in about 25% of women. Another common cause of infertility is tubal factor. So that's positive in about 35% of infertility. Is because the tubes are blocked. So the tubes can be blocked and in many ways. It could be a prior infection. Usually those are like gonorrhea, chlamydia. It could be other infections of the bowel. It may have been a ruptured appendicitis. It could be scarring from past surgery, or it could be endometriosis that causes scarring of the tubes. And we're going to talk a little bit more about endometriosis later. The fallopian tube is what makes a path from the ovary to the uterus. And so that's how the egg gets into the uterus. And so that path, it's kind of like a stream because the tube is making fluid, and that's how the sperm sort of swims to the egg. And the end of the tube is kind of like a vacuum, and that's what picks up the egg and brings it to the sperm. And so if there's a blockage, then people are not going to get pregnant. But all the hormone and cycle is normal. It's just that it's just a roadblock. Most of the time, if people have a factor with the tubes, then the main option is going to be doing IVF or in vitro fertilization, because that bypasses the tubes. Sometimes people are a candidate for surgery. If there's not much damage to the tube, it might be able to be repaired with surgery. Another time that we see that improvements in chance of pregnancy, if people have what's called a hydrosalpinx, that's fluid in the tube. So the tube's usually making fluid every month. It peaks about the time of ovulation, so it kind of makes that stream for things to move on. But if the end of the tube is blocked, that fluid can't get out, and it just fills up the tube like a balloon. And so if people have a hydrosalpinx, that's going to lower chance of pregnancy spontaneously or even with IVF. So it's recommended that that tube's occluded prior to IVF. Or I've seen many patients where they have one tube blocked on one side and the other one's normal. I think the most common case where I see surgically is when there's been an appendicitis and the right tube is blocked and the left tube is normal, and because the appendix is on the right side. And in those patients, if we clip that tube or take out that tube, we increase the chance that someone's going to get pregnant spontaneously through the other tube. The reasons why we think that is the case is mainly that when you have a tube filled up with fluid, it backs up into the uterus and it flushes out the embryo into the vagina, and then people don't get pregnant. And then we can repair that with surgery, correct it. Another factor as far as fertility goes is age. And so we know that as women age, that they have fewer eggs and they have more abnormal eggs. And so women are not ever making new eggs. They're depleted throughout your life. I think of it as like you're born with a bank, and then you're constantly making withdrawals each month on your number of eggs. So how many eggs you start with depends both on your paternal side and your maternal side. So if you had a family that has like late menopause and kids late in life, you tend to have more eggs than the average person. But there's also environmental factors, because we know several cases of identical twins where one has a normal number of eggs and the other doesn't have any eggs. And so typically women are born with usually about 2 million eggs, and then it's about 500,000 at puberty and 1,000 at menopause. And so somehow the ovary seems to know how many eggs a woman has. And so if there's fewer eggs, then you make fewer each month. So normally women in their 20s make about 20 eggs a month, and then women in their 50s make 1 egg a month. And that group of eggs started 3 to 6 months ago. And typically what happens is one of those eggs gets released, and then the rest of the eggs get destroyed each month. And then there's a new group of eggs the next month. So the lower number of eggs doesn't really affect your chance of pregnancy very much. And so, but it does affect your ability to do, say, IVF, because IVF is not a very efficient process. And so you need a lot of eggs to do IVF, because we're just not as good in the lab as you are in the body. And the other issue with age is that there's more abnormal eggs. And so what happens is that if an egg's been sitting dormant for a long period of time, so the connection of the chromosomes is not normal. And so what happens is when the cell splits, you don't get an even number of chromosomes in each egg. And so normally what happens when an egg splits is all the chromosomes line up in the center, and then and they separate, and one set of chromosomes goes to one egg and the other set of chromosomes goes to the other egg. But if one egg gets 2 of the chromosomes, or another egg gets only 1 of the chromosomes, then they're going to be chromosomally abnormal. And so that's the reason why Down syndrome increases with age. And so if you get an extra chromosome 21 in one egg, then that's going to be result in Down syndrome. But there's, all of the chromosomes can be abnormal. So you can have one extra or one less of all of the chromosomes. Most of the time, if you're missing a chromosome, it never gets to the point of viability. So we don't ever see a positive pregnancy test. And then some of them, like Down syndrome, or some of them like an extra chromosome, like 18 or 16, might get to the point of a pregnancy, but then people typically will miscarry. So chromosome 21 is one of the few that gets to a live birth. And so since most of these eggs that are abnormal are never going to get to viability, if an abnormal egg is released, people are not going to get pregnant that month. And so since those are also contribute to miscarriages, then miscarriages increase with age. And so if we look at the amount of abnormal eggs, it's not sort of one particular cutoff like age 35, and then it's just a gradual change throughout life. And so if we look at the number of abnormal eggs, it might be like 35% of the eggs are abnormal in someone in their 20s, but you may be into the 40s, we might be getting into the 70 to 90% of the eggs are abnormal. So it's harder to get pregnant when more of the eggs are abnormal. And for that's the same reasons why there's higher chance of miscarriage with age. And so if you're looking in your 20s, it might be a 10% chance of miscarriage, but by 40, it might be 50%, and by 44, it might be 70%. And so it doesn't say you can't get pregnant, but it says, it may take longer and there might be higher chance of miscarriages. That's very different than in men. And men are constantly making new sperm. And so every time a cell divides, there's a chance for error. So in men, it's more like new genetic disorders that are increased. And there have been some specific disorders that are associated with advanced age. Advanced male age is also associated with an increased risk of autism spectrum disorders and schizophrenia, and maybe even IQ in children. The way that we test for ovarian reserve, there are a few tests. One of them is we get the FSH and an estrogen level on about day 3 of the period. The FSH hormone is called follicle stimulating hormone, and the follicle is where the egg is. And what happens is if people don't have many eggs, that FSH level is higher. So it's like, I think it was like, the brain, the FSH comes from the pituitary gland in the brain. It's like the FSH is kind of like shouting at the ovaries to make more eggs. And so, FSH, a normal FSH is under 10, and women in the menopause, it's over 40. So if you have fewer eggs, the FSH is usually elevated. Another test we do is the AMH level. So that's the anti-Müllerian hormone. And that's a hormone made by where the follicles, where the eggs are in the ovaries. And so if you have more eggs, then the AMH level is higher. So another test. And again, I don't want people to think that these tests tell you can or can't get pregnant. I've seen people with AMH levels of 0 get pregnant. It's just, it tells us what are kind of the best options for people as far as what type of treatment might work. The last test is what's called the antral follicle count, and that's counting the number of eggs that people are growing. And usually these things are pretty consistent. Your AMH and your antral follicle count are usually pretty consistent each month. They don't change a lot, but they tell us what are good options for people. So, if someone wants to try IVF, we usually need more eggs because it's not very efficient. If someone wants to do fertility drugs, if there are a few eggs, then the fertility drugs might be helpful, because the way they usually work is to get you to release 2 or 3 eggs instead of 1. And so if your egg count is 2 or 3, it still may be helpful to try some fertility medications. But again, that it's not a matter of telling you can and can't get pregnant. It's more a matter of telling you how the best way we can help you to get pregnant. As far as like uterine factors, cervical factors, it's very rare for the cervix to be a cause of infertility. If someone had an abnormal pap smear and had a leap or a cone, they may benefit from doing an insemination because they've lost the cervical mucus. The sperm, it does not live very long in the vagina, only about 6 to 8 hours. It has to get into the cervical mucus to survive and get to the egg. And so we can bypass that by doing insemination in those cases. The other uterine factors can be things that like benign growths of the uterus, like polyps. We know that polyps lower chance of pregnancy. And we know if we remove polyps, that's just a minor outpatient surgery, will increase chance of pregnancy. Fibroids are also benign growths of the uterus. It really depends on where the fibroid is. I say it's location, location, location. So if the fibroid's on the outside of the uterus, it's really not going to impact the chance of pregnancy. If it's on the inside of the uterus and it's significantly distorting the uterus, it might lower chance of pregnancy or more likely increase chance of miscarriage. And so there may be an indication for surgery to remove the fibroids. As far as other causes called peritoneal factor, peritoneum is the lining of the inside of your abdomen or your stomach. And the factors for the peritoneum are there might have been scarring from prior surgery or from infections like an appendicitis. But the one that we think is probably most common is endometriosis. And so endometriosis is present in about 35% of women with infertility. If women have infertility and pain, it's much higher. It's going to be maybe closer to 80%. And so endometriosis is when that inside lining of the uterus that's usually shed each month when you have a period, it goes back through the tubes and then it sticks to places where it shouldn't be. So around your tubes and the ovaries. And that causes a lot of inflammation, which is not a good environment for eggs or for sperm and can lower chance of pregnancy. Endometriosis can also lower chance of pregnancy by causing scarring. And so we don't do a lot of surgeries for endometriosis anymore like we used to, because the surgery doesn't really bump up chance of pregnancy a whole lot. And if someone goes to IVF, if they're a candidate for IVF, they're going to have a much higher chance of pregnancy doing IVF. So if someone does surgery to remove the endometriosis, maybe you'll increase chance of pregnancy from 3 to 4% to 5 to 6%. But if you go to IVF, you might be on average closer to a 50% chance of pregnancy. We really would reserve surgery for people who may be having a lot of pain. It's not a guarantee for pain relief, but most people are going to have pain relief if they have surgery and have the endometriosis removed. Also, if we think there's a cyst there that might interfere with the IVF and collecting eggs, or may not be a cyst that we think is benign, then we're going to recommend surgery for those patients. The chance of pregnancy after surgery still remains, even out a year after surgery, we still see chances of pregnancy. One of the problems with endometriosis is we don't know what causes it. So it frequently comes back, and it might be back about 50% of the time in about 5 years. So we try to get people, if they're having surgery, sort of take advantage of the time shortly after surgery to try to get pregnant. Some of the medications, that we use in fertility can make endometriosis worse. And so endometriosis is stimulated by estrogen. And a lot of the fertility drugs that we use, like clomiphene or injectable meds, can increase your estrogen. They can make it worse. They can have more pain. So we usually will use something like letrozole. So that's not FDA approved for fertility, but letrozole actually works by lowering your estrogen. So in patients with endometriosis, that might be a first line to try to minimize the effect of endometriosis by not worsening pain or causing it more growth. The next thing I was going to talk about, male factor. So that's about 40% of infertility is male factor. So I think people are really surprised that it's almost half of infertility is male factor. And the way we test for that is the semen analysis. And so usually we're going to get 2 semen analyses because anything that's happened during the time that a sperm has developed can affect that semen analysis. So it takes about 7 or so days for sperm to develop. So the things that we usually think that might affect the sperm are things like high temperatures, like having the flu, or surgery, exposure to certain medications. So typically we're going to get 2 semen analyses, and if they're abnormal, refer someone to a urologist for treatment. So there are many reasons why There may be abnormalities in the semen analysis. Some of them are what's called varicoceles or dilated veins. Sometimes there's a cyst that's causing blockage, and those things can be seen on ultrasound. So oftentimes the urologist will order an ultrasound, and those things can be treated surgically to improve the chance of pregnancy. Sometimes we don't see any sperm on a semen analysis, and those are usually due to blockages or lack of production, and those can be due to genetic disorders such as cystic fibrosis or Klinefelter's is an extra chromosome, or maybe missing a part of the Y chromosome. That's called Y chromosome deletions. And those, the usual treatment is going to be surgery, so that a urologist retrieves sperm from the testis, and that can be used to do IVF. Other things that we see is if the sperm is going into the urine, that's called retrograde. Though that usually occurs in people who have neurological disorders, so problems with the nerves, like that typically occurs in people who are diabetics, and that's easy to treat because we can usually just give people Alka-Seltzer and then alkalinize the urine and then just do inseminations. But there's other medications that we can take in, such as Sudafed and antidepressants that can help that situation. So there are many reasons why men may have infertility, and like I said, usually the urologist is going to be the best person to evaluate that and determine what's the best option for men as far as treatment goes. Unexplained infertility is only about 10% of the people with infertility. It's like, well, we've done all the testing, we don't know why people are not getting pregnant. People often start with a combination of fertility medications and insemination and when it's unexplained. But the real significant increases in chance of pregnancy are if someone is going to do IVF. We think the reason why is because we can do things with IVF that we can't test for. So, for example, someone might have a fertilization problem, and that could be an egg problem or it could be a sperm problem, more likely sperm. But and so with IVF, we can pick up a single sperm and put it into the egg. That's called intracytoplasmic sperm injection. Sometimes we notice that the embryos are not hatching. So human embryos have a shell around it. It's called the zona. And then we can hatch that embryo and help people conceive. The other things with IVF, you're bypassing things. So maybe there is something inflammatory, or like endometriosis that we don't see that might be lowering chance of pregnancy. So for all those reasons, IVF is going to have the highest chance of pregnancy. As far as environmental things lowering chance of pregnancy, we know that smoking lowers chance of pregnancy. We also know that secondhand smoke affects chance of pregnancy. There's other things like caffeine in women, not in men. It improves sperm movement in men, but in women, it takes longer to get pregnant, and it has associated with a higher chance of miscarriage. Lubricants like KY jelly and Astroguide affect sperm motility, so they might lower chance of pregnancy. NSAIDs like Advil, Motrin, Aleve they might trap an egg inside the ovary so it doesn't get released, and aspirin may do the same thing. Acetaminophen or Tylenol shouldn't affect the ovulation from the ovary. Alcohol is not very strong. Maybe 2 drinks a day might affect chance of pregnancy, but it's not a strong factor to diminish the chance of pregnancy. But those are some of the environmental factors that might lower chance of pregnancy.